this work we did with some people from Ogun State on FGS, like female genital schistosomiasis. The problem was given by people who are on field work on parasitology from Ogun State, and I think that should be the first paper on FGS in Nigeria. And it was accepted. I'm sorry, it was published today, and I'm very happy. I must tell you because the project has been for like 2 years. It was published in a Q1 journal and Springer, and we are very very happy. It was one of my master students. Where is she? Ronke. Now she's the one that did that work. So it was a real life project, real world project, and we really thank God for that. The news is coming while we are here, so it's a good starting point for us. I want to appreciate every one of us, even though we had little each. I mean, it's part of it, and then we need to still continue to move on. Now, the subject of the matter in this meeting is um, infectious disease, modeling and analytics, and then climate change. Now, we all know, if you are in tune with what is going on, that the issue of climate change is a global phenomenon. And a lot of places where there has been a kind of reduction in certain disease, we are seeing resurgence, we are seeing reemergence of certain diseases in certain places. And it's a challenge, and then we need to find a way around it. How do we, like one of the things I said in the morning was we need to find solution for problems. So, and that is why we are on heights. So when there are problems, the next thought is there must. So if in mathematics you said if there exists, then, so if there exists a problem, then there must be at least one solution. At least one solution. So, and then the solution may be unique. And so we are trying to see how do we use mathematics to explore climate change dynamics and then infectious disease. Now, when we say climate change, I want to first ask, what's our understanding of climate change? Climate change. So, who is going to tell me? We already started. Climate change. What's our understanding of climate change? Yes? Yes, sir.
I've read somewhere where it says that climate change is a natural phenomenon. It don't necessarily mean that it's because people are burning fossil fuels. That's why it's happening. It could happen as a result of the dynamics of the earth and climate in general. So to recap, I would say climate change is the redistribution of climate variables either locally or globally.
Okay. Yes. Any other? Yeah. Okay. There's somebody here. We have a female. Yeah. Let's give a female first.
Happens when there are releases of greenhouse gases that affect the environment, that affect human, affect agricultures, and some other things.
Okay. Yes. Okay. Okay. There's someone there. I will listen to one more person.
I would just say that climate change, changes in climatic conditions as a result of human activities. I think that's it.
Okay. Yes. Climate change.
Okay. Climate change is the increase in the Earth's temperature leading to global warming. That's the question of the ozone layer.
Yeah.
Thank you.
Thank you. Yeah, that is very strong points he made there, like temperature increase. Yeah, because it's a long-term dynamics of temperature increase over a long period of time. And it's not just um, caused by, there are natural influence and there are also human influence. The activity of the sun and then the volcano eruptions and all of that. But apart from that, somebody mentioned that, what's it called? We have the side of the natural, and we also have the side of the human activity, like the burning of fossil fuels and then the greenhouse effect and all of that. And then over time, we are seeing the changes in temperature in different locations all over the world. And now this is having effect on several infectious diseases. Like there are places where malaria and quite a number of other diseases have been wiped out before. But due to climate change, we are seeing an upsurge in such a location. And then this is giving us a kind of a kind of thought that what is going to happen now. Are we still going to continue in this trend over time? Some of the time we are also seeing seasonality. We are seeing seasonality that is driven by some of these climatic variables like temperature, like rainfall, like the wind patterns and all of that. So where is the pointer, please? Okay. Where's the pointer? Okay, next, please. Okay, so looking at malaria, for example, you find out that you find that you have the mosquito, the influence of the mosquito, that's the female Anopheles mosquito, and then you have the parasites, and then you have the human, and then for the human, you find out that there is an asexual phase of the cycle of the parasite that goes on in the human, and then the sexual phase goes on in the mosquito. That's the Anopheles, female Anopheles mosquito. And then what we have observed is that in the process of the sexual phase, the life cycle of the parasite, which is the Plasmodium falciparum parasite, that's the PF malaria. We have about 5 kinds of species of malaria that brings malaria parasite. But the most prevalent one in Nigeria is the PF. That's the PF malaria, and which is the most virulent. And in other places, we have what's it called? Plasmodium knowlesi, Plasmodium vivax, Plasmodium ovale, and then there's one other one, if I can remember now. Yes, Plasmodium. I didn't hear you. Malaria here, yeah. So, but the most prevalent in Nigeria is Plasmodium falciparum, and we have noticed that there's a certain temperature, like when the temperature of the environment it's less than 16 degrees centigrade, the parasite in the mosquito cannot really thrive. So after some time, because the mosquito also have a life cycle of about 28 days. Now, if peradventure in the course of the development of the parasite, the temperature is quite lower, and then that is not favorable for the parasites to develop. So what happens is, there may not be continuous transmission because the temperature does not really suit. But once temperature is rising above 16 to around 30, then it's still okay for the mosquitoes to survive and thrive, Once it's above 30, then there's a problem. The mosquito cannot also survive, because when the heat is too much, or when it is too cold or too hot, then mosquito also may not be able to survive. We also have the impact of rainfall. There is a certain mmHg of rainfall that washes all the breeding sites, and then you don't find the mosquito thriving. And then there is also a level of rainfall that allow many breeding sites. And then at that period of time, you find out that a lot of mosquito abundance is everywhere, and that brings about more transmission and then more incidents of malaria in that location. So now the overview, now we're talking about basic concepts: public health, epidemiology, climatology, and then public health approach. And then we have the time and space scales, the climate risk management, and all that. Now, public health. Now, you see, we need to build this foundation, because I was saying in the morning that there's no way you want to understand what we'll be doing in the course of this week if you don't have the understanding of the biology, the climate, the theory of climate, the theory of public health, the theory around epidemiology. So we need the understanding as we travel together to be able to see how we can begin to bring some of these components together, and then we'll begin to develop models going forward. Now, so public health is what we as a society, what we do collectively to protect, to promote, and to restore people's health. So what we do, public. There's also a global health. There's global health. Global health has to do with what. So that's it, at the aim of WHO and all these big organizations. But public health is what we as a society do collectively to protect, to promote, and to restore the people's health. Or we can say the science and art of preventing disease. Now, one thing in public health and epidemiology is when there is a disease, the next thing is, how do we control this disease? That's the main thing at the heart of Federal Ministry of Health, WHO, NCDC, NMEP, all those places you are seeing. How do we control so that this disease will not kill people? So that a lot of people will not die. That is, it will not increase mortality. Now, because when you are in a population, and just like take for instance COVID, when COVID came, it was, there was one COVID that has been, that's SARS-CoV-1, but the SARS-CoV-2 was different. The SARS-CoV-2 was different, and then the scientists were trying to understand what kind of disease is this. So in trying to understand, they asked everybody to stay at home. Because in terms of the virulence, the rate at which it was transmitting everywhere, under few weeks, a lot of people have been infected, and then nobody understood the transmission dynamics of that disease. And that was why we had to stay back home. Everybody stay back home. And then while we are at home, some people are busy thinking, looking for way out, how this disease will stop. Because if it doesn't stop, even look at it, when it stopped, it has affected the economy. Now you can see the post-COVID challenge. After COVID, a lot of people ran out of this country. We are still in it till today. The economy changed. A lot of things were affected. So many businesses all over the world collapsed. Until date, so that's one of the challenges about disease. When it's spreading, now, especially when it's a pandemic, that's like a global spread of a particular disease. There's a challenge. So the goal of public health is how do we prevent the disease? How do we prolong life, the life of people? and promote health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. This is not moving. So you find out that everybody will start looking for solution. And so for COVID, because there was no solution, we're asked to stay at home. And then in the course of staying at home, we began to think about, now the first thing to do then was to start developing models. Somebody called me from WHO and said, okay, what can we really say about the situation on ground? What is the modeling saying? So we need to get to the table and then begin to think around how do we respond to what is going on in terms of what can mathematics tell us, especially about the transmission dynamics, because you can't, it's not ethical to begin to gather human being, especially at that time when you don't know how the disease is spreading. So I can gather them and then you are doing a test or something. No, it's not possible. So the next thing to do was to look at the population level solution in terms of developing a model to see how the disease is spreading in the population. So we began to see the need. This thing is not moving. So we began to see the need to use model to influence what is going on and also to understand. At that level, people need to understand transmission dynamics, how the disease is spreading all over the world, and especially in Nigeria. Take for instance. Now, and what determines that? You will find out that for Nigeria, the population pyramid of Nigeria is quite different from other countries of the world. You find out that Nigeria has roughly more than 60% of its population as young people. Are you getting what I'm saying now? So, and that was how we developed an age structure model that puts people in different age groups. So COVID was more of an age structured model disease. So, and then we needed to look at, okay, certain age, like people from age 0 to 5, and then like that, different groups. And then you find out that disease is a function of population, time, and space. That means location. So the way COVID was transmitting in Nigeria was different from the way it was transmitting in the UK. The reason is because the population pyramid of Nigeria is different from that of UK. So, and that is why in my talk in the morning, I said that we are no longer interested in Tokumbo models, imported models. Now, they have been doing that before, like you go and import models. Somebody is doing a model for us, for Nigeria in UK, that does not understand the population dynamics of Nigeria. He doesn't even know what is going on in Benue State. Let's say Oboko here, and then you have the data. You don't understand the topography, the geography of that location. So that comes into play in terms of disease spread. The population you are dealing with, in terms of their demography, their age, their genetical makeup, their nutritional status, I'm even going beyond the normal stuff, and that means at individual levels, because those are the things that actually determines whether a disease will thrive, starting from individual to the population. So now, looking at globalization, globalization and global change. So increase in interpopulation connectivities and increase in scale and intensity of action. Now you find out that since 1970 going forward, there has been globalization in terms of many travels, especially with the advent of aircraft. People are able to move from one location to the other better than before. And there is movement of people going from Nigeria to Europe, to America, South America, Australia, Antarctica, and all of these are means by which disease spread. I was reading a story around the mpox, and then that's monkeypox, and then there was this story that in the recent time people traveled and then they found out that mpox through travel, some people were infected, like through infected immigrants went to Germany from Nigeria, and then people who doesn't have the case of mpox before begin to spread with the population, and then there was need to do a kind of surveillance. Now, how did this thing came about? Where was the source of this spread that we are looking at? And it came through travels. People, you get infected in Nigeria, you travel to Europe, and then because you are asymptomatic, you are not showing any symptoms, but you are spreading in the population. You don't know. There are diseases like that. We'll be talking during this week that somebody is sitting down here. A lot of us are 80% of people in Nigeria that are asymptomatic to malaria. They are just moving around, traveling here and there, but you are asymptomatic. And those are the people that is making elimination to be very difficult to track. So looking at some of these factors like demographic changes, like I was saying for COVID, you find that it's an age structure thing, and then people in Europe that are more elderly generation group, like people who have immunosuppressed system, they are battling with other diseases, and then COVID came, they will die very easily because once it affects their lungs and all of that, somebody who is having underlying issues, and then before you know it, is gone. So the question that was being asked, they were asking me, some group from Oxford during that video, was by now Nigeria is supposed to have, the air system of Nigeria is supposed to have collapsed. That's now, and normally that's supposed to be the true case because in terms of air system, we are nowhere to be found. Yes, but the question was the fact that COVID was an age structure thing, and then most of the people that were affected in Nigeria, they were a young population that doesn't have any immunosuppressed system. So somebody had COVID, he just wake up in the morning, he brushed his teeth and drank hot water and started going to his job again. Then after a few days, COVID left him because he's a young man. But people in Europe who had underlying issues, like they have high blood pressure, they have lung disease, they have other issues, they have cancers and all that. So once COVID, get to them, what happened is that the thing began to spread, and then before you know it, they are dead. So it's a different ball game in Nigeria, where there are more than 60% of the population who are very young and maybe between their 15 and 45 thereabouts, and then they are bouncing around and all that. So population growth also, Nigeria since 2006, we have not done any population census. So what we are just having online, they are just population projection. They are two different things. Now, population projection in the sense that you know that at a certain percentage, each state, this particular state is increasing. So you factor it into the, I don't know where there's no matter here. I will have just giving you the Malthus growth model. With that, you can calculate of the population of Nigeria in your seat there while you are sitting down. And then you tell me the population of Nigeria as at today. At N naught equals to, yes. So just a very simple so where if you are taking from N naught is the initial, so our base year should be 2006. 2006, what was the census? 2006, what was it? 140 million. So 140 million. So maybe, so with this, if you can track this, you find the solution to the present what should it be by 2025 with this? The R there is the bet minus debt. No, the bet minus debt. This is just a simple one, but I didn't want to make it complex by including other, because we may not have information on the immigration number of people that are coming in, and then between now and that time, a lot of people have left Nigeria. These are also things to factor into this kind of model. But with this, you can get an idea of what the population will be from 2006 till date going forward. Now, we also have urbanization. You know, the demographic changes is being affected by urbanization. A lot of cities, between 2006 and now, development has taken place. There are places that don't have good roads before. They are becoming big cities. You know, things are getting better and all of that. And then there is a way this affects the public health. Look at, take for instance, Lagos State. There's nobody naturally that will believe that Lagos State will be one of the lowest states with malaria prevalence in Nigeria. But do you know that Lagos State is one of the states that, in fact, I think is the lowest in terms of prevalence of malaria in Nigeria? And the reason is because of urbanization. A lot of people are educated, and then they take to the rule. Some are sleeping under net. Some have a lot of other preventive measures and that they put together and all of that will make them to like prevent malaria. Increased density, aging, and then increased density, then aging. Aging also is a factor, demographic factor. Increased mobility, you know, people move from one place to the other in search of job opportunity. You find somebody's when Abuja, and then you find that some people are living in Nasarawa, but they are working in Abuja. So in the night, mosquito biting in the night at Nasarawa, because they commute between Nasarawa and Abuja. So mosquito biting in the night, and then over time, he got sick. Not at Nasarawa now. He got sick while in the office. So being able to trace where people live, stay at night, where they live, where they commute within, is a very important factor in tracking public health issues and even epidemiological, so diseases, whether infectious or non-infectious. Take for instance when COVID came. Now, the guy that brought COVID to Nigeria was an Italian guy, 28-year-old guy. He traveled from Italy for a job. He was going to Ogun State, a place in Ogun State, on February 28th. That was the first case we recorded. So all the people in that flight, they were tracked down by what we call contact tracing. People who had contact with the first case that was recorded, they had to check. So they have become a suspected case, right? Suspected case is different from confirmed case. When you have not been tested, you are not confirmed until you are tested. So we call them unconfirmed suspected case because they have had contact with somebody who is carrying COVID. So they put all of them in one, that was why they were doing, quarantine, to check after some time whether they are going to be showing some symptoms, and then they will track them. So that was what happened that time. And then, so the issue of mobility, family structures can also have influence when people are sleeping, 20 people sleeping in one room. Yes. So 20 people, family structures can influence some of these things we are talking about. So, and then now social changes, institution, governance, the policy we are making, international codes, cultural diffusion. So they all have impact on population health. So the economic activity in terms of trade and capital mobility, people move because they want to get better life, and then in the course of moving, it's either they had contact with disease while moving, and then they spread. This disease is spreading all over. Now we also have large scale and systemic environmental impact, degradation of land and water. Those are, all these factors we are talking about, they are factors that have great impact on on the health of the population in terms of it makes several populations to become vulnerable to disease. So you have depletion of resources, ecosystem disturbance, disruption, and then climate system. So that's another issue. This is not moving. Okay, so the figure is a schematic representation of the three major domains: social, economic, environmental, within which globalizing processes and changes are occurring. Now you find out that all of these have, when you come about disease, there's a social aspect of disease. Take for instance Lassa fever now. There are some states in Nigeria that are high burdened for Lassa fever. When you go there, you have to be very careful of what you take. Places like Ebonyi State, you go there, what's it called? Ondo State, Edo State, Bauchi. Benue is not high burden. It's there, but it's not high burden. So when I mean high burden, I mean that they are on top list when it comes to Lassa fever. Now, so when you go to such places, you find out that there are socio-cultural impacts of the disease in terms of some people like to eat rats, bushmeat, and in the preparation of such stuff, you find out that some are not well done, and then in the course of it, there is transmission going on, and then the economic aspect also come into play in disease transmission. You find out that if you are buoyant, you can go to hospital, you take care of yourself, you take good medication. But if you are financially crippled, you find out that maybe you go to all these chemist shop, you are feeling cold, they will give you one drug like that, and then most times we are treating symptoms. We are not treating the roots of the disease, because you cannot. When you are feeling symptoms, I think you should go for test. But in Nigeria, we don't do that. Diagnostic test. Now, when the large number of us here, anytime you are feeling symptoms, the next thing you are thinking is malaria. It's malaria. I know the solution. You go and collect one chloroquine somewhere, and then you take. And then they pack all those nonsense for you and put it, and you are using it. After 2 days, the cold or the headache is gone. You are feeling good. But you are only treating symptoms. So we call it presumptive treatment. So a lot of us practice that. You don't go for tests. And then those are populations that are actually making malaria to be difficult in Nigeria to track. So because we don't have information about such people, data is not, they are not reported. So unreported cases. So you are not reporting, we don't know. So those populations are quite very difficult to track. So soon, and their main component, the two-way interaction between them and all that. So I'm moving. Now, public health approach. Now, when there is issue with population health, what do we do at the public health level? The first thing we do is surveillance. So surveillance tries to track what is the problem? What is going on? What is the problem? What's the problem? Like, take for instance COVID now. So people begin to do surveillance. Now, in trying to do surveillance, one of the things we do, apart from taking data from various locations, sometimes you don't even know where the hotspots of the disease is. And that's why in surveillance these days, especially the way things have grown, there is what we call the geospatial models. So the geospatial models is one of the, like, your geospatial analysis. You are able to know the hotspots of certain, like some of the places I mentioned that Lassa fever is high burden. It was due to geospatial analysis that was done that made us to know these are the hotspots of Lassa fever in Nigeria. So you are able to know the hotspot. It started from the story of Jon Snow. How many of us have heard Jon Snow before? Jon Snow. Some of you who have done epidemiology or public health, Jon Snow. Okay, so you know Jon Snow now. There was cholera in the UK. You understand? And then the next thing is they couldn't trace where this thing was coming from until they trace it to a particular tap. Aha. So, and then from there, so that was how the idea of geospatial came from. Came from the theory of Jon Snow. So once they were able to deal with that place, the cholera stopped in that location. You understand? So being able to identify hotspots of certain diseases is very important, and this is part of the thing that comes with surveillance and all that. So, and then in surveillance also, we also deal with issues around the modeling, because the main purpose of public health is to control disease, find intervention to control disease spread. If disease is spreading, do you know that all of us cannot travel? We can't travel. You can't do your normal academic something and all that. So everything will be closed down. During COVID, churches were closed down. Everybody went online. You understand? Sunday service were closed down. Everything shut. Few schools were doing online class. If you are in a government university, I'm not sure there was any provision as at that time. So you find out that you are locked. So another thing we also look at in public health approach is the risk factor identification. So what's the cause of this disease? Let's take, for instance, malaria now. What's the risk factor for malaria? Who's going to tell me? Yes? Risk factor for malaria. Stagnant water. So if I pour stagnant water on your body now, you have malaria, have you? No, I don't want a chorus answer. If you know it, can you stand up and tell me yes? Good. Female Anopheles mosquito. That's the risk factor. Not stagnant water. Because if I pour stagnant water on your body, you cannot have malaria. Can you have malaria? So the PF, Plasmodium, is not also the direct risk factor. You understand? Because the mosquito, if the parasite does not find a reservoir, there is no way it can thrive. So it finds the mosquito as a house, and then the mosquito is busy. He comes to your area in the morning, and then when he can't find you, when you come back in the night, like when we came there yesterday, when I was standing outside, they came to visit me. When I was there, they know that I'm now in Benue. Anywhere you go, they will look for you because of CO2. Right? So once you are able to breathe out CO2, then they get you. Right? So the risk factor for malaria is Anopheles mosquito. So what's the risk factor for lung cancer? The risk factor for lung cancer? Smoking. Yes, smoking. So if you are smoking, you are very much likely to have lung cancer. Not immediately, because it's a chronic disease. So when I say chronic, it's a long-term disease. Over time, it's not something that will come immediately. But even if it doesn't come immediately, your lungs cannot be stronger like my own now, that I've never smoked in my life. You don't know. Your lung will be very weak. If the two of us ask that we should not breathe for like 5 minutes, you will struggle, or 10 minutes. Right? So because there is an issue with the lung because of smoking. So we have several other diseases like that. So then the other thing is we begin to think of, now after we have, for COVID, what was the risk factor for COVID? Yes? Risk factor for COVID. Infected person around you. No, infected person. Generally infected person. anything that he's doing, it can give you infected and okay, let me say infected. Yes, infectious, but like some people are asymptomatic. When you say infectious, it means that this person is symptomatically infectious. If you say symptomatically infectious, he's already showing symptoms. But the person that is not showing symptoms is at subclinical level. He's not showing symptoms, but he's moving around, he's coughing, and then all of you are collecting, you are laughing, and then he's giving you. Do you understand? And then before you know it, they are testing people. They say, "Wow, so everybody here has gotten COVID." So, and then the next thing we are thinking about, what is the intervention? Intervention. So for COVID, there was no any intervention. So what was the intervention we were using for COVID when it came? Social distancing. Those are non-pharmaceutical, NPIs. They are non-pharmaceutical because the disease was new. It was new. So nobody understand the dynamics of the disease. We need to understand the dynamics of the disease. So, and then in waiting to understand the dynamics of the disease, what were we doing? We began to look out for ways, measures to reduce morbidity. What do I mean by morbidity? Disease burden. So that it doesn't increase. We don't get more people getting the disease. So they have to make us to separate. So now how many meter am I going to be in social distancing? What's the meter? No, it's not 5. 1.5. 1.5 meter. So between you and the other person, what informed 1.5 was modeling. They didn't just say, it's in Nigeria, just say 20 meter. Yeah, all of you. No. They went and did the model, collect data. That was what informed 1.5. Do you understand me now? So, and it worked. So, if it's just thinking about Nigeria alone, you just say, okay, you people here, because I know you are my family member, you be 5 meter. This guy, I don't know him. Let him be 50 meter away from you. Then that one, we get fiber mark. Let him be 55 meter away from this place. And then you find out that we are not going to track anything. So those 1.5 meter, even in the course of it, they were still taking data to check. And in the course of waiting for the right intervention, they were modeling. And then the modeling was saying, okay, they were forecasting that, okay, this if you vaccinate 80%, what is going to happen? They put it to test. And then they saw the number of people that theoretically went down. And then if we vaccinate 100, and then eventually, now vaccination normally is meant for people who are susceptible, right? In the population, you use it to reduce the number of people who are susceptible so that they can become immune due to the vaccine. We call it vaccine induced immunity. Now, we knew that there are natural immunity scientifically, but immunity is an elusive thing. Do you know why? This person's immunity is not the same as this person's immunity. So at the population level, the conclusion was that immunity is an heterogeneous thing. It varies. So in terms of when you say natural immunity, for measles it was easy because you will at least have measles once in your lifetime. Yes, and shows the symptoms. But for COVID, it's not like that. For measles, we cannot factor in asymptomatic. There are dynamics about disease. You cannot just sit down and say, you sit down in your house and you are formulating something that is not realistic to what is going on in the dynamics of the disease. You can't do that. So that was why in the morning I was emphasizing the aspect of the biology. If you don't know the biology of a disease, don't dabble into modeling it. If you hear that they are modeling anything, you get and sit down and understand the biology. Measles is a viral disease. COVID is a viral disease. But the dynamics of their transmission are not the same. So you find out that for COVID, while COVID is spreading in the population, silently killing people and bringing immunity down, a lot of people are infected and they are moving here and there, and then they could still travel and all that. They were testing for interventions. So at the end of the day, there was what we call indiscriminate intervention, vaccination. You have to vaccine everybody, right? That's for COVID. There was no, whether you are infected or you are infectious, you are immune, anything you are. The question is, all of us must be vaccinated. Because that was what the modeling showed. And that was why I was in a meeting last week and I told them, if malaria is going to go down in Nigeria, the R naught for malaria is 100. So there is what we call hard immunity. That means someone else's immunity can help you. So if you have, hard immunity, HIT is equal to, this is the formula. So if malaria is this 1 minus 1 over R naught. So if malaria is 100, right? So it means that 1 all over 1 all over 100, which is equal to what? 1 minus 0.01, which is what? 0.99, which is approximately 1. So which is 100%. So everybody in Nigeria must either take R21 or RTSS, so that, still combined with the available intervention, everybody must be vaccinated. So for measles, you find out that you are seeing outbreak every year. Every year there is outbreak. Why? Because there are a lot of unvaccinated. And there are so many misinformation about vaccination. And that affects people. So, I don't want to vaccinate though. Or they want to come and collect my blood. In fact, during COVID, some people said that when you, after the vaccination, that if you put anything here, the magnet, it will magnetize. So when I collected it, I put a magnet or something. The thing did not magnetize. So on social media, you can see now, people were saying so many funny things. And so that's why as a scientist, you don't follow social media, you read books. You don't use social media as a conclusion. Yes, I'm not seeing my slide anymore. ID. Okay. So, okay, as I was saying now, so a lot of funny stories around COVID-19 during that time. I also wondered how people who are in science were also following that kind of thing. It was a strange thing for me. And so, because in Nigeria now we don't read. If you want to know whether people are reading, just keep something inside the book. What he's looking for, keep it there. After 2 months, ask him, that thing you are looking for, have you seen it? I'm still looking for it. He has not been reading it. So we don't read. So if you don't read, you don't know. So, and I think we have to change that. Indirect protection that comes because some people are protected. You have an indirect protection. Now, if the R naught for COVID-19 is 5, right? So I have a 1 minus 1 over 5, which is equal to 1 minus what? 0.2, okay? Which is what? Which is what? So we just need 80% of the population to be vaccinated. We don't need to vaccinate everybody. So their own vaccination can help the rest of the population. That's indirect protection. Between here and here, there is modeling. Implementation. Now, the implementation means that now, how do we target intervention strategies? You understand? Intervention strategies. You want to know that which intervention should we deploy to Benue? Which intervention should we deploy to Jos? Which intervention should we deploy? What are the states that are close to Benue State? Taraba. Which intervention? Should we deploy the same kind of intervention to Taraba? The one we deploy to Benue? Nasarawa? Kogi? I know you cannot just say, okay, that intervention work for Benue, so it must work for Taraba. No. How do we know that? We go back to modeling. You get the data. Now, in the course of this meeting, we are going to do some models around time series models and forecast. We may show some few results on how, when you look at this population and say, you have Mafa and then Konduga and you know Konduga, Mafa, Konduga, Maiduguri, and then the other one is Jere, 4 local governments. And when we did the modeling, we're seeing that what's it called? There are 2 major local governments that are sharing the same kind of transmission cycles. That means the cycles of the spread of the disease, they are quite common and are peak at certain time of the year, which shows us that even some local government that are even closer at times, you may not, their cycles may not be the same. So if you don't put it into modeling to see, you will just make conclusion. And that was why we are saying in the morning that now, on what are we making our decision? The policy we are making, on what? Is it just telling people that, oh, when you go to bank today, the only amount you can collect is 4,000, it's 5,000. So where did the government come about that? That's the question when I go to bank, I ask, now this model you are using, where did you come about it? You don't know the data in Nigeria, that Nigeria is an heterogeneous setting. And then for you, malaria in Nigeria, number 1 top in malaria, followed by another state in, I think maybe Sokoto in the northeast. So you find out that some of these places they are high burden areas for malaria. And do you know the number of money that is being spent on intervention for those states? Despite that, the malaria is not going down. So you now ask why. It is wrong. So modeling comes into play by it helping you to optimize intervention. You have many interventions. How do you optimize those interventions? Maybe you have 5 interventions, 3 interventions, and then you are able to optimize. You build model to predict the optimal intervention for that particular location. And then from there, you are able to come out with, oh, this intervention will work for this place, this may not work for this place, and all of that. Now, this is different from optimal control. Some of you who are doing optimal control, most of those optimal control are not going to work in real life. They are just to publish paper and make you smile. They are academic exercise. Are you getting me now? So we'll talk about it in the course of the week. The thing is going down here. This one, they are academic exercise to make you happy, and then you rejoice. Say they sent the paper was accepted, but nobody is using it. Yes. So why we are here is that we want to build policy-driven models that is useful as evidence-based outputs. Right? So next. Okay, thank you. Okay, so we want to look at, I have them here, the 17 Sustainable Development Goals. Now, in the course of the week, we are going to group us into different groups where we will look at this. So, number 1 is no poverty, 0 hunger. These are areas you can apply mathematical modeling. And then these are areas where you can find funding. Any science you are doing that is not around this, you are only, you see what you are doing? You are dancing like people, like the children of Israel, who were supposed to spend 40 days. They spent 40 years in the wilderness. You are just dancing around the point without really eating the reality. Any science you are doing, whether you are in medicine, you are in public health, you are in pharmacy, you are agriculture, you are anywhere, and it's not towards all of these 17, you have not started. I must tell you critically today. In the 21st century, when you are in pharmacy, you are in biology, you are in physics, no poverty. That's the problem we want to solve. We have poverty in Nigeria. How do we solve it? 0 hunger. There are issues. Now, each of those ones, they have their subtips. So, if you go and check them online, how you can think about someone. So, we'll be brainstorming about this kind of thing in the course of this week. These are things to think about. These are where the fundings are. You are an upcoming young scientist, an early career person. These are the things you'll be thinking about. So, good health and well-being. That's one we are dealing with this week. I mean, these 2 weeks. That's this SDG 3. We are looking at this 2 weeks. Now, quality education. Quality education. Now, we got, like some few months ago, I just called the academic, is it academic affair or no, people who are in charge of admission. I said, okay, can you send us your data of admission in our university? So let's try something on it. So we wanted to do a model that will forecast at least for 2 years so that the university can prepare. So like it's like an early warning, like predictive modeling for early warning system. So that you can be warned earlier. This we are seeing this in the next 2 years. This is likely going to happen. There's going to be an offshoot. So we did the model and we forecasted for 2 years, and we saw that the population of students that we are going to have in Oye Ekiti is going to shoot up, poor. That if the university is not prepared, even the classes are not going to be enough. The lecturers are going to be in trouble. And we did the, I mean, these are things. So that's why I said modeling can guide many things ahead of time. So in the course of this week, you also see like a geospatial map of this meeting where people have come. So we are trying to, maybe we'll do that before you go. You can see it, that where people have come from various locations in Nigeria. You see the map, and then you can see some of the hot spots of where people came most from mapping point of view. So then we also have clean water and sanitation. Clean water and sanitation. Somebody was discussing with me there. She's a civil engineer, and then she was talking about water pollution and all of that. So this is problem of interest. SDG number 6. 7, affordable and clean energy. Affordable and clean energy. That is another problem. The problem in Nigeria. So how many people are going to sit down and think about solving this area, and then decent work and economic growth? Now you can see the growth, right. So there's an upward trend here. So, but I'm not sure our own is going this path. This is more of a cyclical pattern. So industry, innovation, and infrastructure, the problem. There are less industry, but the challenge also I see is that there are also less skillful people. There are jobs, there are many problems to solve, but there are less skillful people. People who have the skill to do the job. That's it. So, and then reduce inequalities. That's another problem. And then we have sustainable cities and communities. We have SDG 12, responsible consumption and production. Who are the people going to solve that kind of problem in Nigeria and in Africa? Climate action is part of what we are looking at also this week. 13, that's 14, life below water. How do we conserve fishery? Now, we call that one ecological model, the modeling of the aquatic world. And then we have life on land. Life on land can be two, human and animal. So it's also part of what we are looking at. Now, number 16 is peace, justice, and strong institution. How do we build that? In the midst of banditry and kidnapping. So what's the way forward? So we need to start thinking. Partnership for the goals. So, and then, so we need network. Somebody say networking works. We need network. That is, we need to network. We need to come together to build a strong modeling community in Nigeria. That's what we are trying to do now. Building strong modeling and analytic community. Are you getting me now? We need it. In case, let me tell you, at the end of these 2 weeks, I want to see people stirred up. I've seen some people that I've seen last year in our meeting here, but in case there's any pandemic, you are the next person I'm going to call to do the work together. Yes. It's not going to be like before. During COVID-19, there were nobody to call. Nobody. So we want to stop that paradigm. So somebody is going to carry Nigerian money, change it from naira to dollar, and go and give one white man that does not know anything. So, but I think now there's a trust that's been built on us, and we can do the job. Are you getting me now? So we need to solve our problem by ourselves. No white man will come here to solve your problem for you. I must tell you today. They will collect your gold, collect your minerals, and use it to do what? In those days when Indians are coming here, when they were teaching in Nigeria, let me tell you, every Indian man does not forget his country. It's only Nigerians or African people, they go anywhere. When you speak to them, somebody who is a Yoruba man that normally chop amala here. What do you mean? Sorry, Indian man, anywhere he goes, he remains the same. I'm telling you, anywhere an Indian man goes, he doesn't change. No matter, you will know that this man is an Indian man. And what will he do? All his money. Where does he carry it to? Like India. Oh. Indian money, no, they remain for Nigeria. Oh. Indian man go back to India in rupees. Indian rupees. So we need to start thinking like that. And if we don't start thinking like that, if any one of us continue to complain, you grumble, you don't do anything, everything will remain the same. So we start solving our problem by ourselves. That's why we are here. 17 SDG. There are many. We can begin to think about. We have what it takes to do it if you are ready. Are you getting me now? So, yes, I want to see my slide. I don't know how many minutes I have left. So, even if I don't finish this, I think we can continue tomorrow. Now, epidemiology, that's the basic science of public health. examine the evidence. So it has to do with the study of the distribution and determinants of health-related state or events in specified population, and the application of this study to the control of health problems. So you see one thing about, now I was saying in the morning, mathematics, when it got married to epidemiology, we have mathematical epidemiology. The marriage between mathematics and biology gave us mathematical biology. The marriage between mathematics and theology gave us mathematical theology. The marriage between mathematics and pharmacy gave us mathematical pharmacy, which is pharmacokinetics or pharmacodynamics. Now, the marriage between mathematics and physiology gave us mathematical physiology. The marriage between mathematics and psychology gave us mathematical psychology. The marriage between mathematics and English gave us mathematical English, etc. So now what I'm saying, you can confirm them online. There's mathematical, in fact, there's a book, Mathematical English. There's a textbook. Yeah, it's not a joke. Yes, if you want to see it, when we finish, I can show you online, Mathematical English. So so that was why I appreciate what our father was saying in the morning. And there is need to build mathematical models into all the curriculums from undergraduate. So if somebody is doing biology and he knows the mathematics or mathematical modeling that is relevant for biology, he will be interested in studying. So we will not need to wait till they have graduated before they start using modeling skills. Do you understand me now? So we will not need to wait for that. So let's go on. It's not going on. In specified population. Now, next. Okay, so epidemiology 6 to 1 describe health states, assess determinants. What are those things that determine disease spread? Then manage risk. That is, make decisions about interventions, analyze their impact, and evaluate program success. So in epidemiology, we talk about frequency and distribution of health states, determine possible causal relationship between hosts, the infectious agents, and the environmental factors. Now, on these aspects, epidemiology seeks to describe health states. How does it do that? By using frequency and distribution of health states. Frequency and distribution of health states. Now, you find out that, I don't know, I don't have this is malaria, cases of malaria cases in Benue State. And then this is time. Time is in, maybe, let me say, months. From, let's say 2015, January, February, March, April, like monthly data, up till 2025. How many minutes do I have left? 5 minutes. I remain 5 minutes left. Okay. I'll stop. So now, what we look at here from 2015 to 2025. Sorry that I left the other one. So we are looking at the cases of malaria. I said from January 2015. So sorry, from here. So we have something like this. Just to give an example anyway. you know. So what we are seeing here is like the incidence of malaria. So the incidence is the number of new cases of malaria at a over a long period of time. So it's always longitudinal. Now, so this is showing the frequency of malaria. So there are three things we can say about this, and this is the last thing I'm going to say today. Now, this is a kind of a time series plot of malaria. If you have a data on malaria over this long period, this is like 10 years. So we are seeing a frequency, the frequency at which the cases. Now, one of the things we'll see here is like we are seeing a kind of maybe a bit of a trend, right? It's not so sharp, but like a trend, something like this. That's an upward trend. Now, if you also look at it, that's one component of this thing. Number two component is that you also see seasonality. Now, what is seasonality? Now, seasonality is systematic peak of infection at certain time of the year. Seasonality. Than when you are having a regular peak and a repeated one. When it is regular and when it is repeated. So that's number two component. Number three, that we also see this frequency distribution possible that you can also see is the cyclical pattern. Now the cyclical pattern also shows that you are having a peak that is regular but not repeated. No repetition. Do you understand? That's the difference between seasonality and cyclical pattern. Now, for seasonality, you are seeing a peak, and the peak is regular, is repeated. Regular and repeated in the sense that maybe every June 2015, there's a peak. June 2016, the same peak. That's seasonality. June 2017, the same peak. Now, cyclical, you are seeing a peak, but it's not every June. It's changing. That's cyclical. Those are possible things you can see about the frequency of cases about any disease. So I'm going to stop here. I don't know if there are questions.
Lecture for a start, where we will continue by God's grace. Now, I know that many of us, we have questions, we have things to clarify. We'd like you to signify. I will give you a number so that we can control that, and then we don't want question to give out to question because of our time. So I'll start from that end. I'll give number 1, number 2, number 3, number 4, number 5, number 6, number 7, number 8. Okay. All right, can we have number 1? Please pass the mic.
Thank you, sir, for the first presentation. My name is Toussaint from Benin Republic. Prof, is it possible to repeat again the different components you are explaining?
The frequency.
Yeah, frequency, the seasonality.
So the first one was that's a trend components. You know, like when you have a time series data like this, there's a trend component, and then there is a seasonal pattern or seasonal component, there's a cyclical. So the seasonal, you see that the trend is either you are having an upward trend or you are having a downward trend. So when there's a downward trend, it means that there's a depletion, there's a decline, the disease is declining, and there could be many reasons for that. Now, I've not also thought, because there are many things, when I say trend, you know, there are many things that can make a disease to be going down, downward trend or upward trend. There are many factors, underlying factors. So you are just seeing the upward trend and you cannot say why. Is it that there are interventions in place? Is it that there are some things are not working if it's going down? You know, there are a lot of things that I may not be able to say vividly, but we are seeing an upward trend that we need to test. And then you see seasonal. Seasonality, I said, is a systematic peak of infection at certain time of the year. So which can be regular and repetitive. So in terms of, you see a peak in June 2015, June 2016, a peak, June 2017, June 2018, that's seasonality. Are you getting me now? Because you are seeing the peak is regular and is repetitive. Now, for cyclical pattern, you are seeing a peak is regular but not repetitive, in the sense that it could be a peak in January, and then the next January, the same peak is not there. Maybe it's another February, not the same time in the year. So that is cyclical pattern. Are you fine?
I have a few questions I noted down. Number 1, you started by introducing us to public health, and recently there's would I call it a new concept or a new trend for One Health? Is it very distinct from public health? That's the first question.
Okay.
The second question, you talked about R0 reproduction number, where you're using an example, possibly an hypothetical example for Nigeria. I want to ask, if we have R0 for the country, does it cascade to the various states, or the R0 could be different at state level? And then number 3, you talked about a formula 1 minus 1 over R0. I wanted clarification if that formula is what we use to determine the number of population that should be vaccinated.
Okay.
And then the fourth question is, can we say that cyclical or cyclicality that we observe from patterns could be as a result of climate changes? Those are the questions I have. Thank you, sir.
Thank you.
All right, thank you so much.
So from the last one, the last question you were asking, yeah, there are a lot of factors that can make your data to be showing a cyclical pattern. So, and then that will also make you as a scientist, because now if you are going to be a scientist, you must be a doubter. If you are not a doubter, you are not going to be a good scientist. Now, you must learn how to doubt. When you see something, you will say, how, why, what, and that leads you to another thing. So when I see cyclical, there are many things that is running in my mind. So I need to get more data to check. Are you getting me now? So I can bring in climate data and decompose it and check, and even checking from descriptive level. You start some of this analysis from descriptive level, checking the correlation. You understand? Then you can move to regression, things like that, and check whether the pattern you are seeing, does it have anything to do with the climate variability or anything. And then if you are seeing seasonality, you understand? Seasonality in the sense, like we have dry season in Nigeria, we have wet season, So if I'm seeing seasonality, this pattern every June, what normally happen in June in that location, we need to ask. And then we get the data, say, okay, every June, why are we recording this kind of issue? So if you get the data and you're able to check from your data and you are seeing some relationship, maybe it could be many things, maybe vegetation index. And you understand, even environmental issues can also cause that. There is difference between climatic factors and environmental issues. When you talk about environmental, they are local things, localized. But when you talk about climatic, you are talking about a global something that is affecting large number of things. So the other one on reproduction number, so now the reproduction number is a quantity in epidemiology, so which helps us to know the number of secondary cases due to one primary case in a completely susceptible population, the average number of secondary cases. So that R0 for a particular state, R0 for malaria in Benue may be different from that of Kogi State. Yes, may be different. So it's heterogeneous. And then, so until we know the R0, and then the best time to know the R0 is when the epidemic has just started, not when people have started using intervention. When intervention has come into play, we begin to talk about the effective reproduction number, which is far less than the R0. You understand? So these are things that we may distinct each other. So for malaria now, we already knew what the R0 was when it started, and we have the information. That was why I said 100. So the HIT formula I gave you has to do with the herd immunity threshold. HIT, herd immunity threshold, meaning that if I need to vaccinate a certain population due to the knowledge of my R0, you understand? So if R0 is for COVID-19, maybe for Benue State is 5, then all that we'll be looking for is 80% of people in Benue State to vaccinate. Right? If we have that, it means that the remaining 20% in Benue State will have indirect protection due to the protection of the 80%. So I don't know if I finished the question. Okay, yeah. Public health, One Health. So public health is what we do as human beings in our society. Now, the society now the One Health approach is now a method in public health. So One Health has to do with the human, the animal, and then their environment. So all encompass is a method, an approach in solving public health issues. Yeah.
All right, thank you so much, Prof. Yeah, the next person, about 3. Okay, answered, great. Okay, so let's.
Thank you, Prof. I sincerely appreciate your delivery. Actually, most of the things you were saying, well, I can visualize it in what we've been doing. But then 2 things I want to raise. Number one, you said when we have data and then we carry out analysis and then one interpret it, we see pattern. We interpret it. and it ends up in the shelf, something of that nature, or just end up as publications. What, like in, for example, we have the data, the hypothetical data you've given now.
Yeah.
How can one use it in such a way that it will not end up in the shelf? Then number two, you talked about malaria and then how temperature affects. I started thinking, curious, could it be the reason why sometimes people have malaria, in the daytime they're okay, then in the night they become feverish, and something of that nature? I don't know. Thank you, sir.
All right, Prof.
Okay, the last one you said, those are within those dynamics. You know, like when it comes to disease, there is like when I say within those, that means within an individual. Like the rate at which disease depletes your system is different from the other person. So it's a factor of your nutritional status, your genetics, and all that. So the understanding that plays around between, okay, you are feeling feverish in the morning, and then in the night you are not feeling feverish. Now there are many undertones around that we need to find out. You understand what I'm saying now? So now when you feel fever, does not mean that it's malaria. It could be other things. It could be Lassa fever. You understand? It could be what's it called? Mpox. You know, a lot of disease shares some symptoms with malaria. I know in Nigeria, everything will boils down to malaria. Everything. Malaria is having many bad names. Everything is malaria. Just like when somebody did something by the devil. So everything is not malaria. You have to diagnose. That's what WHO said. After the diagnosis, then you can say whether it's malaria or it's something else. Okay? Then the other one is now talking about data. Now you are doing a modeling and it's a theoretical studies. Now, like I was saying the other time, you know, the most recent exam I had in a particular school, as an external examiner, was it not Kogiani? So, you know, the students did very, very, very powerful work. But the question is, you know, when I say powerful work, they were hardworking, but everything was theoretical. So at the end of the study, the guy wrote a recommendation. And I was laughing. To who? Because the question is, which data did you use? So which population are you directing your recommendation to? So the problem is that as a mathematical modeler, you have carried out a modeling that is theoretical, that is not speaking to any population. Now, tomorrow when we come, we'll begin to talk about how we deal with modeling in terms of epidemiology. You have to consider the person, the population, the demography, the time, and then the place. So disease spread is a function of population, the function of time, a function of location. So you cannot sit down in your room and develop one model and then say that all of you in Benue State, I recommend to you that you should be wearing a suit so that and then, you know, the next thing they will ask is that, please, can you give us the data you use? The public health people. Can you show us your data? No, I don't have data. I just did the model. Then your model is just theoretical. So you cannot use that. Now, we were trying to, in our center, at a point, we were going to NCDC to get data. But I went with my student to get some data. We went to do some training in Abuja for some people. And when we went to NCDC, we wanted to see the DG to be able to assess them and help them. They didn't listen to us. So the next thing we did, I said, oh boy, let's find their data and solve their problem. So we got data on MPOS. And then after getting the data, we worked on it, and then we did a forecast for 2 years. And the paper was published in BMC, infectious disease. Was it last month? BMC infectious disease. So last month, it's a Q1 journal. And then the next thing was that I sent it to the PA of the DG. Said, immediately as I was sending it, this guy, anytime I send message to him, doesn't listen. Said, we need to meet to discuss this matter after Ide Kaba. I said, no problem. So now, from that point, what I'm saying is that you cannot speak to a population or recommend anything to a population that you are not critically work on their data. Are you getting me now? So the reason why we are able to speak to the population was because we had the data and we use it to do the forecasting. Are you getting me now? And the guy said, we need to discuss these results. And then after, you will take it to the DG. So the system we are trying to penetrate was easy for us because we solved the problem they could not solve. So if you want to penetrate a system, get their data. You want to penetrate World Bank, get the data, solve the problem in your group, and then send it to their DG. Then from there, you start talking. Are you getting me now? So I think that is one of the ways to do it.
Okay, thank you, Prof.
Thank you so much, Prof. So I have a question. When you were teaching, you made reference to optimal control in academic field not being relevant or
Yes,
something
ma'am.
like that, like just to make somebody feel
You feel happy.
happy and all that.
I feel good.
Is it because the data are not true?
Which data?
Like the data that they use are not from the right source. That is why you made the statement. Or why? And how can optimal control be more practical than the academic ones that we have seen in the
Now,
materials?
have you seen any of the optimal control using any data?
Sir?
Did you see any of the optimal control using data? Which data did you use? Come, give it to him. Which data did you use?
Okay, like for me on COVID-19,
Yes.
I've used NCDC data.
What kind of data?
Well, it's the public incidents anyway.
Eh?
It's the public incidents that they publish in their websites.
Incidents.
The public incident statistics, they publish it on their websites.
Is it incidents or cumulative incidents?
No, during COVID-19, they had, apart from the population, they have monthly publication.
Yeah.
So you can look at it at a particular season.
Okay.
Yes, I did document control my work.
Yeah, what I mean is you cannot use, you see now, the optimal control you are seeing in theory, when you go to the streets, it doesn't work. That's why, you see, that's why I was telling you that the way you are seeing it in paper, that one you did, it's not the same when it gets to the field.
But we did a parameterization where you collect the data and you use the data to obtain the parameters for the model. Then, now, you use your optimal control code, like from your Python, and now use the...
I understand all those things you use. Do you understand? The method and all of that. But you see, what we are saying is that now, I appreciate what you have done, but all of that are still, they are theoretical. Because the thing is now, in terms of the optimal control you made use of, right? Like the social distance you put in your model, right? So, wait. Did you have data from NCDC on enlightenment, on the educational campaign? No, in your control. Did you have data for that?
Like from the flow diagram. When you, like from in my own case, the control we did was we looked at enlightenment for vaccination.
Yeah.
We also look at enlightenment for treatment with isolation. Not only isolation.
So how do you treat COVID? Is there treatment for COVID?
There are drugs like some of these anti-inflammatory drugs like Udemisa that were effective.
But it's just to treat the symptoms. You don't use it to treat COVID. You don't know.
But when you manage the patient has chances of recovery more than the person that is not
So that's why I'm saying that when you say treatment, you should specify what kind of unspecified treatment. Just like Lassa fever now, you are using ribavirin. Ribavirin is not a drug directly to treat the Lassa virus. It's just to treat the symptoms. Just like COVID. COVID does not have a specified treatment. It has what's it called? It has That was why we look for vaccination, to take, for people to take vaccination. So what I'm saying is, like, take for instance for your educational campaign, did you have data for the treatment? That treatment you put, do you have data for the treatment?
You know, if you do a good optimal control code.
No. What I mean is, do you have data? That's my question. Do you have data for the control, those enlightenment rates? Do you have data for the?
So, in the case of optimal control, when you subject the data, the model to optimal control,
That's theoretical. That's what I'm saying. There is no data. You see, let me tell you, in the course of this meeting, we are going to show you malaria data. By the grace of God, we work with a National Malaria Elimination Program. Our center is a consultant for National Malaria Elimination on modeling. Now we have access to the NMDR, that's National Malaria Data Repository. Now you cannot want to do a modeling that has to do with control, and then there's no data for control. And then you see impact of educational campaign. Where? Do you understand me now? Now, let me even ask you. Now, which educational campaign was done in Nigeria at that time for treatment? Tell me. In your local government, it was done. I understand you. You see, what I'm telling you, that you are only use conceptual knowledge. Just concept, which is good, but it's not enough. When it comes to practical life situation, you understand? Nobody will listen to you because you don't have data to prove what you are talking about. Take for instance now, when they were doing the campaign, well, I mean, how many number of people do they give in terms of access and then usage of those things were captured? These are things you need to understand. It's not just, you see, it's good that you are here so that in the course of the 2 weeks, you will see how we have been doing it by the grace of God. So, yes, ask your question.
Sorry, since I'm talking, let me use the opportunity to ask my question. I have a case with FMC Owerri.
Okay.
I applied for data, clinical data.
Okay.
And they subjected me to the ethical committee.
Okay.
If the ethical committee told them to tell me we will not release this data because of sensitive nature, they were just frustrating me. So how do we bypass such hurdles to get real data?
Okay. Now, what kind of data were you requesting for? Because you see, let me tell you something. As mathematicians, most times, for me, when I was starting, I don't also know the language. You understand? I had to learn the language. The many of you say clinical data. What do you mean by clinical data? Now the man is looking at you. This one is not even talking what we are. Do you understand? He doesn't have the language, so he feels that, let me not listen. I went to somebody in UCH in those days when I was trying to do my PhD, and I was talking. I need this data. He said, "You don't know malaria yet. Go and sit down with malaria biology." Yes, she told me. She's very blunt. She told me, and that was why I had to sit down. You understand? You know, all these things I'm saying now, I sat down to read them. I'm a mathematician by training from University of Ibadan. But I have to sit down to learn the biology, the climatology, the pathogenesis, everything about all the G's, about the disease. You have to sit down. If you don't sit down and you go to somebody in public health and you are saying, I need clinical data, and say, hey, which kind of clinical data? And you don't even know. You understand? There will be a problem. So because in the course of this, we don't have time today, maybe we'll look at this. Somebody there is going to look at disease data, and then we'll look at when you see a prevalence data, when you see a panel data, when you see a longitudinal data, when it is incidence data. What do you mean by it? All those things, cross-sectional data. Are you getting me now? Because you cannot just say, I need a data. When you say cross-sectional data, you also talk about the scale of the data. There are data that they don't have time scale. And then you are looking for, how do I do this with time? It's not time evolution. It could be age. So if it's age, it means that it's going to go towards a PDE, partial differential equation. So you need to create. So these are things you need to understand in dealing with real life situation. So you don't just sit there and say, I need data. Which kind of data? Cross-sectional data, prevalence data, Are you talking of panel data, longitudinal data? A lot of data. So you must know the kind of data you want. Not just say clinical data. The person will look at you and say, this one does not know what he's talking about. What do you mean by clinical data? You need the language of the people you want to assess or you want to help. If you don't have their language, they just say, well, we cannot start talking. Go and learn first. So as mathematicians, we have, you see, mathematicians, we have the method. All those, you see, he was telling me optimal control. He knows, he has so those things in his head. But the problem is that how do we now marry with somebody who is in biology or public health? That's why we are here. How we are going to. So from now, you see that optimal control, we will use it, but in a way that at the end of the day, we are using it with real-time data from maybe that impact of education. You see every month, the record they are having. You understand? You can use it maybe on DHS data that captures cross-sectional stuff. You can now bring up that parameter and take the average and use it in your model. You trace where you got it for that particular state. And then somebody can begin to say, you are making sense. Are you getting me now? So I think that's the idea.
Okay, thank you. Let me see the remaining hands up.
Okay.
She
has not finished her question.
You mean you are not done? Or something came up later? Okay, let me allow you to finish up. No, we didn't have any hand here. We didn't have hands in that place.
My question is not yet answered in a simple language.
Okay.
Yes, sir. Because the question I asked was that how can we now know the optimal control that is in the real sense, like in the real life situation, since all these ones that we normally do? Is it because of data? That is why the results are
the primary thing is that you don't have data, you cannot say anything. Like now, you don't have data about Benue State. You are saying that you did optimal control and then it's going down like this. For where? You don't understand what I'm saying now. For it's just that one is just theoretical, just like exercise in a textbook. That's not. Do you understand? When it comes to public health, nobody will listen to you when you are saying the thing is going down. Where?
Egypt.
In which state? Are you getting me now? So that's the question. Nobody listening to you there and say, please, can you tell us which data you use and all that? The coverage they are talking about, which control intervention, when was it deployed, between what year and what year? These are the things they want to hear. Are you getting me now? So the underlying thing is that you are doing a theoretical study. And you see now, the challenge now is that when you see most of the models, it's the same. Positivity, bandedness, invariant region, density analysis, production number. I can tell you, if I see a modeling paper, everything that will be there. That's the challenge. We want to take us beyond that in this meeting. Beyond all those levels, especially some of us who are mathematicians. And then those people who are coming from health, public health, the approach is quantitative. So you see, we have two approaches in modeling in epidemiology of infectious disease. We have the qualitative approach and then the quantitative approach. The quantitative approach is what helps the community. That's what we use when I was talking about the operational modeling that can drive policy, modeling that can convince evidence-based approach. That's quantitative. You are telling somebody that, okay, this certain number of disease will be averted, maybe 800 if we do this based on our model. Then you are talking. Then the guy said that, how much are we going to spend to do that? So the policymaker want to know, if I'm going to invest in vaccine, this vaccine you are saying that is working, is bringing like 5,000 people down. How much is it going to cost me? So if it's costing less, then they are happy. They want to listen to you. So these are things we need to start thinking about. Not just saying that the optimal control where we did this, U1, U2, U3, and all of that. The thing is going down. Downward. And then the control profile. You see, let me tell you, we have done all those things. We are tired of it. Are you getting me now? And we are saying Now, going forward, what do we do? Now, some of us who are interested in the dynamical system thing, you know, it also has to come from the point of view of question. Now, most of the places we have been, you see somebody, and these are things we also need to deal with here. People are mixing objective with methodology. Now, when you look at objective, carry out sensitivity analysis, carry out this, carry out. Then when you look at methodology, carry out compartmental model using ODE, perform sensitivity analysis, reproduction number. Then when you look at objective and methodology, they are the same. That's the challenge. So everybody is doing virtually the same thing. You are just changing parameter. This one say theta here, this one change alpha here. Carry out optimal control. Carry out this one use U1. This time you are using U1 as LL line. The next time you are using U1 as treatment, ACT. And then what you are doing is just swapping. You are swapping U1, U2. You swap, you change it. You publish another one. Say U3. You added U3. So it's published. So the question I want to ask you, what new thing are you learning in terms of the mathematics when you do such work? What new thing did you learn in terms of the public health or epidemiology when you do such work? What impact does your paper have to the community when you do such work? I think these are things we need to think about going forward. Are you getting me now? So nobody wants to listen to you when everything is just theoretical. Now, when the disease has just started, and then we don't understand the dynamics of the disease, and then you want to use modeling to understand how the transmission dynamics is going on, that is welcome. At that period, that's the basic level. It's like a descriptive epidemiology. Do you know that the largest publication we have made in Nigeria as far as modeling is concerned is just descriptive? It's descriptive. Just basic, just like doing a box plot. You know, everybody is doing just the same thing, and we need to change that direction. So, enough is enough. We need to come from the approach where we address modeling from the point of view of question, not from the point of view of methodology or objective. Now, the objective we even claim is not the objective that's supposed to be, because the question does not come from math. The question comes from the epidemiology of the disease, not from math. The tool to solve the problem is from mathematics. Okay.
All right, let me see the remaining hands up so that we can. Okay, so those two hands, let's try to.
Good evening, Prof. Good evening, Prof.
AOB.
Good, sir.
Okay, sir.
Yes, sir. While you are talking about R naught. While the lecture was on, you are talking about R naught, and I just want to ask a question about if one is working on a model and it happened.
Please, can you listen to his question so that we can all learn from it?
If you are working on a model and it happens that your R naught is around something like 5, is it that you are wrong, or is there a range that R naught must be?
No. I mean, I cannot say you are wrong. I mean, it's even positive. It's not negative. So there's no problem if your R naught is 5. It depends on a lot of things, the parameters you use in your model and all that. So, but if it's 5, you know, now the thing is, if you now compare that result with existing results, do you understand? And that's why you see now, what have people done in that area? Existing results. And then you also come from the point of view of the data, because you can, like, what I'm emphasizing is that you cannot just say that what's it called? You developed the model and you didn't use the data from Benue State, and you are recommending for Benue State. Does that sound wise? Does it make sense? Or you are saying this model is meant for Nigeria, and ordinary, even the average lifespan of Nigeria was not factored into the model. If we check your average lifespan, it was even for Somalia or for another country. Are you getting me now? And then maybe you use a particular paper that was published in Europe, and then you look at it, you modify the work, and use their parameter, and then you are now saying for Nigeria. Do you know that that's, it doesn't make sense except you have a data, and then the demographical factors in your model, they are Nigerian oriented. Everything is Nigeria oriented in terms of your mortality rate and all that, So those are the things, and the birth rates. You are factoring birth rate of Europe into your model parameter because the paper you use is from Europe. And then you are saying that if Nigerian government should adopt this kind of thing, nobody will listen to you. Are you getting me now? So unless you use data that is Nigeria oriented and it was collected for Nigeria or from Benue State, and you are using it to solve their problem, they will begin to listen to you.
All right, thank you, sir. Okay.
Thank you, sir. My name is Godwin K. My question is brief, actually. That HIT equation, one over R naught, how do you determine the knot, the R naught? Did you randomly plug in that value? How do you determine the R naught?
Okay. R naught. Okay, we use, there is what we call next generation method. So now we know that, thank you. When disease is spreading, now it starts from one person, right? So this guy that came from Italy, this guy, and then one person can at least infect two persons. So we do like this. So we are building a tree, and then goes on. You can see the tree is growing. Now, if this disease is not truncated from the first generation, this is the first generation, the second generation, the third generation, this R naught is 3. The third and the fourth, that's R naught is 4. It's growing. So the number of people that will have been infected is growing. So what we mean by R naught is just a dimensionless quantity, right? A dimensionless quantity that that shows the number of the average number of secondary cases. Now this is a primary case, and these are the secondary cases. You understand? In a completely susceptible population. So these are secondary cases due to this one primary case. You understand? So that, I think that's just the idea behind the R naught. It's not random. You can see from there. You see that one person came, and then from one person, at least 2 persons can be infected. Do you understand me? And then from these 2 persons, look at it now. From these 2 persons, this one person can infect another 2 persons, and then this one person another 2 persons, and then this one person another 2 persons, and then the whole thing is growing. So at that time, do you know what is happening in the population? You know this velocity time graph. You have this, and then the disease is growing like this. And the question is, when is it going to come down? There's a linear growth going up because the number of people that are infected are getting increased. It's going up. So at this point is when this R naught. So as this is going up, what is happening here is that the people, this thing is happening underneath. That's why this one is going. This one is infecting this, and this one is shooting up. From 1 to 2 to 3 to 4 to 5 to 6 to 7. This one infected this and this, 8 and all that. So this is the time you can calculate the R naught, the exponential growth.
All right, thank you so much. Of course,
Then
in the course of the
formula.
training, you will get to be taught how to calculate R
For this
naught.
one,
Yes.
we'll teach you
In
that.
the course of the
It's going to
training,
come.
you
We'll
will
show you,
you'll be taught.
especially
Yeah.
for
Okay, thank you so much. So let me permit this person who never raised his hand. I think Grace is covering for you.
Yes. Thank you so much, Prof, for the enlightenment. You were talking about the surge of malaria, and most of the things we've been looking at physical parameters. Okay, we talked about CO2, we talked about Anopheles mosquitoes. But then there are certain things that causes treatment failure. You mentioned them, pharmacokinetics and pharmacodynamics. Now, for therapeutic failure, that also causes a surge, in malaria. So are there ways of modeling biological systems, failure of drugs into this, factoring it in?
there's somebody at the back. Stand up.
See Aaron at the back.
Odogu
That is his
Barara.
work. His current work. Treatment failure. Yeah.
So it's modeling. It's a parasitology by training, but it's modeling. He's been trained as a modeler, and he's working on treatment failure. So it's possible.
My name is Tayo. Thank you so much for that brilliant lecture. My question, I think, maybe to round up, it's a yes or no question. Would it be right for me to say that without data, there's no model?
No. There is model. This thing, I'm going to.
It can be theoretical.
So the only thing is that it's not one. There are two things about model. We have not started. This what we are just doing is just preliminary. I've not entered modeling. What I discussed today is just climate and public health. You understand? I've not started modeling. Now, modeling. There are two major things about modeling. Insight. You want to gain insight. Number two, prediction. Now, within these two, there are three trade-offs I will be talking going forward. The first one is transparency, flexibility, and then accuracy. Now, if a model is going to inform prediction, it must have a high level of accuracy. What do I mean? Underline the word high level of what? Accuracy. Prediction is just like, let me give you two models here. A toy, a bicycle, and an aircraft. Now, if you want to travel by bicycle between here, Benue State and Ekiti that we are coming from, you know what is going to happen to you now? I don't need to tell you the story. Even for some of us that took a bus. Are you getting me now? So in terms of the time, the distance, and then the cost. The cost will be minimal in terms of money. Maybe the fuel you will buy. But the time and then what? The distance. No, that's number one. Number two is the fact that now what you are going to use to couple a bicycle, like the arrangement of a bicycle, is not what you are going to use for the aircraft. Now, before you can say that an aircraft is a model, an aircraft is a model. But it requires a high level of accuracy, precision. Before it will be launched out, there is going to be some sensitivity analysis tests that will be carried out to know even the specificity of certain equipment, or some of the materials that are put together. They will check the specificity and then the sensitivity of that product before they will say that they are bringing it out, and then they will run the simulation. And it has to be, when I say simulation, they run it like model. You see the simulation like this. You will see everything before you can be launched and said, this aircraft is certified, it can carry people. Are you getting me now? That's a very complex model. That's why, you see, those of us that are doing theoretical model, you can sleep tonight, sit down here now, and just say, okay, you factor this theta into the model, and then tomorrow morning your model is ready. Go and ask some of us who are doing that are using data. We have been 2 years on the work, 3 years on the work, and it has not been published. You just carry, if we want to be doing that, by now we'll have 150 papers. But that does not take you to anywhere. Do you understand? Nobody will use it. It's not useful. Are you getting me now? So when you are looking at modeling from the point of view of what's it called? Like you said, theoretical. You want to just you want to gain insights. You want to gain insight about the transmission dynamic of the disease. Maybe like for COVID, when it came, we didn't know how it was spreading. We wanted to know how the disease was spreading in the population. That's the starting point. So after that, we should be talking about something deeper than that. And for us to do that going forward, we need data. At the basic level, mathematics can play a lot of roles in understanding. And then in terms of, if I don't have a data, I can come within the limit. You see, that's why if you're a modeler, you must be, generally, if you're a scientist, you must be truthful. That's one thing about science. Science will make you to be truthful. If you want to, if that's the standard of science, are you getting what I'm saying now? In science, normally, you see, people, I don't know, it's because Nigeria, we do things anyhow. If you do, there are people who have been sacked because they falsify data. You don't know? They sack the supervisor, they sack the student. Data falsification can make you to be redundant for life. So it's Nigeria that somebody just do anything and just cook some things together and then no. So what we are saying is now, if you want your model to inform policy, you need data. If you're a mathematician, you want to be modeling for mass, you can be doing that for the mathematics world. And then you are happy, you are doing dynamical systems. But the challenge is I'm seeing in Nigeria is that we have not even grown that kind of capacity. In most of the places that we go, by the grace of God, we're trained in the University of Ibadan, we're trained in both pure and applied mathematics. We have the functional at our left. That is not an issue. But the challenge is that, you see, many of the people we have been to, many of the places we have been to doing examination and all that, the functional is very weak. I challenge some of the students, he carried one very big thesis like this. I was asking, you have developed a model. In the course of the meeting, we'll see a lot of things, I believe. Even to construct an initial value problem is a big thing. Most of the papers we have seen, they are not well constructed. The model are not well defined. And they are published. That the paper is published does not mean that it's good, it's correct. Maybe you don't know. Some of us say they are published the paper. It does not mean that your work is good. It depends on the editorial policy that publish your paper. So the question we must note is that, look, do we really have the conventional approach to solve the problem? That when we are doing things here, is it the same thing with Harvard? That we can stand at par with somebody that is talking in Harvard and we can say, yes, this is correct. That's what we are talking about. At the end of this workshop, that's what we want to try to achieve by the grace of God. Not you being in a place and they say, is this one the professor? You run away, because when you see what you want to present and you see what an undergraduate is showing, you will pick race and quickly fold your this thing and say, well, let's put that one on second this thing. We have heard about that in several places. Because what you want to show is even what people are doing as undergraduate exercise. That's what you are saying you are doing as research. So we need to wake up. So we can do modeling from theoretical point of view, but the question is, in Nigeria, do we have the skill? Because the theory of dynamical system is what many of us lack the training. Virtually in all the 6 geopolitical zones in Nigeria, I can say this with all confidence. Because I've tested in many places. If I sit you down, the model you have constructed, and ask you questions about the theory of dynamical system of that model, you can't Some of you, many of you will not be able to stand it. If I ask what is global stability, the Lyapunov stability, can you tell me some of the properties of a Lyapunov function? You don't know, but you copy it from a paper. Copy and paste, you are just repeating the same thing, but you don't know the theory behind it. Even the optimal control you are designing, do you know the specification of the kind of optimal control you are doing? Problem, formulation. You don't know. Yes. Because when you talk about optimal control problem, there are 3 different kinds of formulation. But Nigeria has stick to one. That's the Lagrangian approach. So when you see their paper, everybody is using the same thing. So I ask, why are you not using the Mayer formulation? Why are you not using the Bose formulation? They don't know. Can you go to board and show me the space that the Lebesgue integrable function that you define there is depending on? You don't know. You don't even know. Those are the challenge. And you want to do the theory. You can't. You don't have the foundation. So we must go back to the foundation. And that's the challenge for this meeting. We must go back to the foundation. Some of us who are already PhD holders, you are just doing like this. Let me tell you, if you don't go and work on your foundation, you will sink. It's not enough to have PhD. PhD is the beginning of research. If you have PhD, and even if you are a professor, that you are a professor is not just a title. What do you profess? Is it that I'm a professor? And so, you are a professor, but you are lifeless. You don't have content. That's the challenge. You are a professor, you don't read again. You have stopped. We read every day. Ask my student. Every day I carry my book, come here. Every day we are checking. I already have about 5 books on my table that I need to finish. You are sitting down there saying that this thing. I need to jot. Even as a professor. You say you are a professor. Is it just a professor? It's just a what's it called? No, it's not for show and be. So let's wake up, Nigerians. And some of us who are lecturers, you are busy doing poultry, doing cement, buying cement. It's not to waste your life. Sit down with your research and have a single eye. Your body will be full of light. The reason why your body is not full of light is because you don't have a single eye. You are doing because you are selling this, all those ones. You are not going to be an outstanding researcher that can solve problems. When you do research, doors will be open to you to do more research. But because of salary, some of us are running from one pillar to pole. When you sit down on quality research, you will move. The reason is because we don't have time for quality research. Just Poru Komisi, put my name, put my name, put my name, put my name. When it's 2 weeks of publication to promotion, Indian Journal of Mathematics, 50 naira, you pay. Malaysia Journal of Science, oh yeah, you publish like 20. Oh yeah, promote me. So all those things it's not going to take us anywhere. So thank you.